It is a weekday morning in England. A patient arrives at their local pharmacy to collect a prescription only to find the shutters down. Not temporarily closed. Gone. This scenario is becoming increasingly common. According to NHS Business Services Authority data analysed by industry bodies and reported by the BBC and the Financial Times, England's community pharmacy network contracted by over 10% between 2015 to 2016 and 2023 to 2024. In 2023 to 2024 alone, there was a net loss of several hundred pharmacies, the largest single-year decline in nearly 2 decades. This is not a marginal change. In 2016, government analysis stated that England had higher pharmacy density than many European countries. Since then, the population has continued to grow and demand for services has risen, yet the pharmacy network has shrunk. Pharmacies are not just retail outlets, they are part of the NHS frontline. Data from NHS England shows that over 1 billion prescription items are dispensed each year in community pharmacies. Millions of people rely on them for repeat prescriptions, medicines advice, vaccinations, and urgent supply of medication. When a pharmacy closes, access to NHS services is reduced, particularly for older patients, people with long-term conditions, and those without easy transport. At first glance, this looks like another high street decline story, but demand for medicines has not fallen. Prescription volumes in England have increased by roughly 1/3 over the past decade, rising from around 800 million items each year to over 1 billion. So if demand is rising, why is the pharmacy network shrinking? The immediate explanation is financial pressure. Multiple parliamentary briefings, National Audit Office reports and coverage by the Financial Times point to the same issue. The current NHS funding model creates severe pressure for community pharmacies, with profit margins at or below sustainable levels. Unlike most businesses, pharmacies providing NHS services cannot freely set prices. The vast majority of their income comes from NHS contracts. Under the Community Pharmacy Contractual Framework, pharmacies are paid for dispensing NHS prescriptions and for delivering specific NHS services. Funding for the core framework remained largely flat in nominal terms between 2015 and 2023. While some targeted payments were introduced, the overall funding envelope did not keep pace with inflation. Over the same period, operating costs increased. Staff costs rose, including pharmacist wages. Energy costs surged during the 2022 to 2023 energy crisis following Russia's invasion of Ukraine. Industry surveys reported that some pharmacies saw their energy costs more than double during the crisis. Government support schemes provided time-limited assistance to businesses, though at lower levels and for shorter durations than household support. Rents and business rates increased. Regulatory and safety requirements expanded. Pharmacy representative bodies calculated that after accounting for inflation, funding fell by roughly 1/3 between 2015 and 2023. In other words, the sector delivered more services to more patients during a period when inflation-adjusted funding declined by approximately 30%. But this alone does not explain the pattern of closures. The pharmacy network has contracted, but it has not disappeared. So what determines who survives? To understand that, you have to look at how the funding model actually works. Community pharmacies receive fees linked to the volume of NHS prescriptions dispensed, fixed establishment payments intended to support the costs of maintaining pharmacy premises, additional payments for specific NHS commissioned services. In theory, this structure favours scale and volume. Larger operators can spread fixed costs across multiple sites, centralize administration, and negotiate better supplier terms. Smaller independent pharmacies cannot access these efficiencies. However, even major chains have struggled. Major chains including Boots closed hundreds of stores between 2022 and 2024, while other large operators have similarly reduced their footprint. Consolidation has affected operators of all sizes, but parliamentary evidence shows that independent pharmacies have been disproportionately affected. Evidence submitted to parliamentary health committees by pharmacy representative bodies, including the National Pharmacy Association, documented that independent pharmacies face particular pressure, especially those with lower prescription volumes. At the same time, the NHS has expanded the clinical role of pharmacies. Pharmacists now routinely deliver services that were previously handled in GP surgeries or are expanded public health services. These services include vaccinations, blood pressure checks, medicines use reviews, emergency supply of medicines. Government policy documents explicitly state that this shift is intended to reduce pressure on GP surgeries. Pharmacy representative bodies argue that funding for these additional services has not fully offset the increased workload and staffing requirements. As a result, pharmacies are providing more clinical services, while the core dispensing model faces increasing financial pressure. Parliamentary evidence shows that smaller operators have been disproportionately affected, with higher rates of closure and sale among independent pharmacies. The pattern of closures is not evenly distributed. Healthwatch England, NHS England, and parliamentary briefings all documented the same finding. Closure rates were higher in more deprived areas, reducing service availability in communities with higher health needs. Rural communities have also been particularly affected. Areas with higher health needs often have fewer remaining pharmacies. When a pharmacy closes, workload does not disappear. GP representative bodies, including the British Medical Association, have reported increased pressure from medication-related queries that pharmacies previously handled. The closure of pharmacies removes a healthcare access point that policy intended to reduce GP workload. Academic research on healthcare access suggests that reduced pharmacy availability may affect medication adherence patterns, though isolating direct causal effects from other contributing factors remains methodologically challenging. This comes at a time when GP surgeries face ongoing recruitment and retention challenges. BMA surveys throughout 2024 documented widespread staffing shortages and extended waiting times for appointments. The National Audit Office has repeatedly noted that pressures in one part of the healthcare system can create pressures elsewhere. This period has also coincided with broader cost of living pressures. Prescription charges in England increased from £9.35 to £9.90 between 2022 and 2024. Patient advocacy groups and healthcare providers have reported cases of patients delaying or not collecting prescriptions due to cost concerns. When pharmacy access becomes more difficult, this may compound adherence challenges. NHS England and parliamentary committees have stated that reduced access to community pharmacy services is likely to increase pressure on GP appointments, NHS 111, and accident and emergency departments. That outcome would undermine the policy aim of shifting care into the community. It is tempting to treat pharmacy closures like shop closures, but pharmacies are not ordinary retailers. They are contracted providers of NHS services, operating under strict regulation, fixed pricing, and public service obligations. Unlike typical businesses, they operate under contracts with fixed pricing and cannot freely adjust their commercial model, relocate without regulatory approval, change their pricing structure, replace NHS income with alternative revenue streams. Analysis by the National Audit Office and parliamentary committees has noted that pharmacy viability is largely determined by government funding policy rather than market forces. Closure patterns reflect policy choices embedded in the funding framework rather than market-driven competition. In October 2023, under the then Conservative government, additional funding was announced for community pharmacy. The 2024 to 2025 settlement included over £600 million in additional funding. This was the first real terms increase in nearly a decade. According to the Department of Health and Social Care, this represented recognition of the financial pressure the sector had faced since 2015. Following the July 2024 general election, the Labour government confirmed the existing 2024 to 2025 funding settlement. As of early 2025, longer-term funding commitments beyond the 2025 to 2026 financial year have not been announced. However, both parliamentary committees and the Financial Times have reported that the increase only partially offset nearly a decade of decline adjusted for inflation. Pharmacy representative bodies report that financial pressure continues across the sector. Parliamentary committees have been told that closures are likely to continue unless there is structural reform to the funding model. Industry reports suggest that closures continued into the financial year from 2024 to 2025, though official full-year data from NHS Business Services Authority will not be available until spring 2025. Consolidation continues. Large chains have closed hundreds of stores since 2022, while smaller independent pharmacies continue to exit the market at disproportionate rates. This raises ongoing questions about access, resilience, and equity, particularly in areas with higher health needs and lower average incomes. Pharmacy closures are not an abstract trend. They affect how people access medicines, they affect how quickly people get care, and they increase the pressure the rest of the NHS has to absorb. For more than a decade, government policy operated on the principle that community pharmacies could deliver expanded services with constrained funding. The data now documents the consequences. The pharmacy network is contracting, not because demand has disappeared, but because the funding structure has not kept pace with operating costs and service expansion. Unless that structure changes, the contraction will continue. Not because pharmacies are unnecessary, but because the funding model has created conditions where a significant number cannot continue to operate profitably.